think somebody that has a high burden of disease, we really need a response, that may be a swaying factor to Dato.
How do you now view the landscape? Let's assume approval of these agents in the first-line setting. How do you now envision the approach to first-line treatment of metastatic TNBC?
Yeah, I mean, so first off, it's great to have choices, right? Patients love having choices. We love having choices. They're two great drugs. I think we have a choice in the PD-L1 negative subgroup now with, not yet, but we will have a choice with datopotamab or sacituzumab govitecan. In the PD-L1 positive subset, we still have that data from ASCO with sacituzumab govitecan in combination with Pembro. So still, when I have somebody with metastatic first-line triple-negative breast cancer, I need to get that PD-L1 test, right?
Mm-hmm. Yeah.
And then that's my first fork in the road. And then I think, honestly, we have the choice between both. I can see myself using both, actually, in some different scenarios. You have a different schedule, you have a different side effect profile. We can bring up some other differences within some of the endpoints of the trial. I don't expect to see OS with sacituzumab govitecan. That actually doesn't influence me in the first-line setting at all, to be quite honest, because of the data from the second-line setting. I think it's a great drug. There's clearly a benefit. The interesting thing we did see was response rate difference. Datopotamab really having a clear, higher response rate in the control arm, and we didn't see that with sacituzumab govitecan. And so I think that left some people kind of asking questions of, well, everything kind of looks similar, but why was that so different? I think the inclusion of that population that progressed quickly on chemo than to kind of go back and get chemo probably helped a little bit on the Dato trial, because you really needed that ADC at that point. But a little unclear why we saw that. So I think somebody that has a high burden of disease, we really need a response, that may be a swaying factor to Dato.
Yeah, I'm really glad that you brought that up, because I was certainly struck by the response rates in TROPION-Breast02. And I think for patients with metastatic disease, when we do deal with symptomatic tumor burden, it tends to be fairly rough in triple-negative breast cancer, right? These are when we do see things like ascites and pleural effusions and so forth. Often that's in the setting of triple-negative breast cancer. So I like your point about we have options, and the option to use an agent that has that kind of a response rate in high-burden disease or highly symptomatic disease, I suspect will translate to a quality-of-life outcome as well, in addition to the efficacy outcome. So it's interesting you point out that we have options, and I'm a huge proponent, as I know you are too, of mutual decision-making with our patients and really patient-centered care. And so now to be able to walk into that conversation with the patient and say, rather than we have limited treatments and this is what you're going to do, to be able to walk into that conversation and offer more than one choice, but also to be able to point out differences between the two agents, as you've pointed out, the schedule, the adverse effect profile, and the trial design differences, to also give us some guidance in terms of treatment selection, I think is helpful in this setting.